with regards to this session, it's actually about virtual assessments. So I will just introduce Larry, who's actually the research assistant, one of the research assistants. He was working with Husna as well as Fahana. They're all wonderful. But Larry is actually a qualified doctor. He's actually from Sarawak, like Janet. And he's currently doing a master's degree with us, looking at life after falls. And the reason why I invited him to actually give this talk is because for the life study, we actually started and we only have limited 2-year funding. And suddenly, as we were trying to ramp up our recruitment, the first cases of COVID-19 appeared in Wuhan. So our PJ population very savvy one. As soon as people think of Wuhan virus, nobody wanted to join our study anymore. It was not necessary. They don't want to catch COVID. So we already started thinking of other ways to actually see our patients, because we know that this pandemic is not going to actually last. It's actually going to last for quite some time, maybe until the end of the study. And we just begun recruitment. So the best option was to actually change the way we actually recruited our participants, as well as how we assessed them, to actually continue to get some participants coming so that we can carry on with our study. So we actually completely changed our way of evaluation to virtual. So Larry is going to now share with you what we actually did in the live study. So over to you, Larry.
Yep. Okay, I'm going to share the screen. Okay. Hi everyone, I'm Larry. I'm actually one of the research assistants in Live project. I have the privilege of working in Live project together with Prof Tan and Dr. Izzati. Personally, I'm working also as a medical doctor. Okay, just as an introduction, Live research team is from University Malaya, and we are trying to help seniors who have suffered from falls. We want to find out how falls actually affect our senior citizens' life. We also want to spread public health awareness and provide access to specialist medical care. So the overall aim of this study is to evaluate post-fall behaviors among the older Malaysians. So our findings will be invaluable in helping us to understand post-fall behavior in older Malaysians in order to inform policy and future research. As you know, as our population ages, the number of older people presenting with falls to healthcare services are also expected to increase exponentially. Falls affect 1 in 4 Malaysians aged over 65 years and above, and are associated with high morbidity and mortality. In addition to that, healthcare costs of treating the fallers are high also. And besides that, older people usually presented with fear of falling, and fear of falling is associated with poorer performance in physical, mobility, and cognitive tests. One major consequence of this fear is the subsequent restriction of activities, leading to inactivity, deconditioning, loss of confidence, and further increased fall risk. Hence, it is not surprised that fear of falling has been found to be associated with frailty and also in older adults. So the restriction of activities caused by fear avoidance behavior also affects participation in social activities, a factor underlying reduced quality of life. So, an introduction to e-life. We are particularly concerned about older persons who have been experiencing falls over this period, as it has been not easy to get medical attention if they needed it, and some may even be reluctant to visit a doctor altogether. As a result, we've launched eLife. Just as the name suggests, eLife is the electronic version of Life Project, as older people are more at risk of complication if they do catch COVID-19. We like to ensure that we can continue to reach out to older persons who had a fall as soon as possible after the fall event without having them to leave their house. And yes, face-to-face interview may lead to the risk of COVID-19 transmission, although the actual risk of this could be considered low. Furthermore, during the movement control order, patient could not be assessed unless this was seen as an emergency. So we therefore elected to undertake a virtual consultations to ensure that older persons who have been fallen are still getting an assessment without the risk of transmission from face-to-face interviews. And this means that we can do the entire interview through video conferencing. However, we are also prepared to do it through a telephone call if the patient prefer to. We have found questions that we can ask which will replace the physical test we are doing. And later I will just give you a brief introduction of what sort of questionnaires that we are using. And yes, we still can check patients' memory balance by asking them a few questions. Just as in Life, based on the answer that we obtain, we'll be making some recommendation on what they can do to prevent another fall in the future. So what is different with eLife is that the recommendation will be taking into account the fact that you do not need to leave your home. Okay, the first things that we actually do when we call patient during a virtual interview is, of course, we will take some demographic details, falls history, medication history, and we will also check on the physical performance using TMAT, stand for Telephone-Based Mobility Assessment Questionnaires. Before COVID-19, when we see patients face-to-face, we will check patients' physical activity physically. But now that we are doing virtual interview, so TMAT was very helpful as it has 4 questions inquiring about the ability of walking a quarter of a mile without a break. Second, the ability to walk a quarter of a mile in 1 hour, difficulty walking, and lastly, walking compared 5 years ago. So this questionnaire can be administered in just 2 minutes. The sensitivity was about 46.2%. Positive predictive value is about 78% for this study. And as for the orthostatic hypotension, we are using OHQ. This is a questionnaire used to ask patients to determine if they have any symptoms developed during when they are standing up or standing from the seat. So this will be determined by, beside that, we also will ask the participants to measure their blood pressures first by lying down using a home blood pressure monitor, and again within 3 minutes of standing up. So if the participant had their own, this is only when the participant have their own blood pressure monitor at home. And we'll use this questionnaires OHQ to determine orthostatic symptoms. So OHQ is a 10-item symptom scale score from 0 to 10. 0 representing no symptoms, and 10 is having the worst possible symptoms. So this questionnaire is also scored in 2 separate domains, symptom assessment and also daily activity scale. Okay, and the third one we'll be using to test the patient's memory will be picture-based memory impairment scale. So this is a cognitive assessment done virtually, comprises of a test consisting of 4 pictures of common objects. So the patient will be asked to look at and remember the objects and subsequently distracted for 1 minute using a mental calculation, for example, -7 from 100. Then the ability to recall the 4 objects will then measure using unclue, and clue recall. Maximum score will be 8, minimum score will be 0. Okay, so we'll be also using blind MOCA, whereby through phone or through virtual interview, we'll be asking patients questions without having them to write on the answer sheet. So for example, can you lift out your hand when you listen to the alphabet A? So patient will then lift out their hands, or they can tap on the table when they listen to a sequence of number with the alphabet A, or we'll ask them to -7 from 100, or to repeat a sentence that I've said. Okay. Beside that, we also use some psychological questionnaires such as DAS-21 to assess whether patients have depression, anxiety, and stress. For few of following, we'll be using Short Fast International. It's a 7-item questionnaires. And for quality of life, we'll be using CARS 12. For physical activity, we'll be using IPAD or PACE questionnaires, stand for Physical Activity Scale for the Elderly. So whenever possible, the patients will be asked to report their physical activity level prior to their incident fall, as well as their physical activity at the point of assessment. So physical activity at the point of assessment will then be validated using a physical activity monitors, which will be worn for 1 week. Okay, so regarding virtual lifestyle intervention and virtual consultations, a management algorithm was developed for face-to-face evaluation as a part of the initial study by an expert panel consisting of geriatricians and eye specialists, rehabilitation physicians, and memory doctors. So this was then modified by the same panel to enable home-based lifestyle interventions. Trigger points for the clinical consultation will be replaced by virtual consultation using Telemed. It's an app whereby it's an online platform which acts as a digital ecosystem between the doctors, patients, and pharmacies that can support messaging, telephone, and video consultations. So advice is then given through information lifted available in 3 languages, and any prescription can be made through a patient's selected pharmacist. So, and the consultation will be carried out by the trained geriatrician from the Falls Clinic at PPUM. And participant, if necessary, will be offered a face-to-face appointment. Okay, this is a pictures of the lovely patients. You know, when we call them, right, they just take a picture of themselves, the patients, and beside the patient was the patient's children and husband. So this is how we do virtual interview from the patients. So actually, it is not hard because most of the patients and most of Malaysians know how to use a iPhone. You know, they're even more sophisticated than me myself. Okay, and actually, I would like to introduce you to our outpost. So when our clinical research become permissible by a relevant authority, a strict SOP will be observed to maximize patient safety. We actually come up with a research outpost whereby when patient, if necessary, we still get to see our patient face to face. And then so we managed. Prof and I managed to find a place where we can rent to be used for our research outpost. So, and this is also ensure for public liability, as no procedures, treatment, or medical consultations will be conducted at the venue. And yeah, so okay, and then I'll show you some things that is inside. Okay, and we have the TFM machines to monitor the autonomic responses of the patients, and the plenty of waiting areas in the outpost. We have consultations table to see the patient face to face. So yeah, and we recognize that this is a very difficult time for everyone, and particularly for those who are over 60 years old. And we do hope that we can make things a little better for you or your patients through this initiative. If you have any interest, or you have anyone who you think might be interested in our study, you can contact us at this number. Okay, I think that's all from my side.
Larry, do you want to leave the last slide up a bit so that people can actually have time to write down the number?
Okay, yeah, sure.
Yeah. Okay. Maybe we'll have a few questions before we move on to the case studies. Yeah. Anyone has any questions? Yeah. Larry, do you want to leave the last slide up? Yeah.
Oh, yeah, sure.
Okay. Any comments? We'll we'd be grateful for any input to actually make this even to make this better. because actually it's been a struggle getting it off the ground because there was a lot of skepticism initially about whether it's going to work or not. But hopefully, it didn't happen overnight. It actually took a lot of persistence on my part because I don't give up. People know, yeah. So, okay, Doctor Dicky says cannot see the number. Maybe you want to read it out to everyone,
Yeah.
Larry.
So the number is 011 5505 3255.
Yeah.
011 5505 3255.
Thanks, Izzati. Yeah. Okay, we'd be happy to share because this is actually public funded research. So anything is supposed to be freely available and including the results. So hopefully other people can do the same thing during the COVID pandemic. And if they find a better solution, please do also share it with us. Yeah. So this is actually our falls hotline. So anybody is allowed to send a message to that hotline at any time in the department, from the emergency department, because what we want to do is to avoid them admitting the patient after a fall. As in the previous workshop, in the previous plenary by Davinder, we actually don't think that inpatients are admitting patients for falls evaluation is actually a very good idea because they decondition while they're actually in hospital. Yeah. So anybody has any burning questions? Not really? Yeah. Okay. So yeah, while you're plucking up your courage, I can carry on talking. Yeah, so Izzati now has a case presentation. We have two case presentations, so it will be about 20 minutes each. Yeah, and then and then after that we'll have a bit of discussion following that. So basically, we've both come up with cases that we see. We call them common garden falls cases that we see as a bread and butter in falls clinics, and then we would like your help as to how to best evaluate them during this COVID-19 pandemic, bearing in mind that repeated visits to hospitals are not recommended because every visit will double, treble, quadruple the chance of actually potentially getting COVID-19. And also we want to reduce the density of patients coming to public hospitals as well. Otherwise physical distancing is not possible. And coming to hospital usually for a patient with falls usually is a three-man job. You actually need the father, the son and the daughter, or the father, the son and the daughter-in-law to all come at the same time. Sometimes the wife also comes along, then they come into Menara Selatan main entrance, cannot come in. So those sort of things need to be addressed, and so we actually would like your input as to how best to make this happen, and hopefully that will also give you some ideas about how to serve this very needy population at this difficult time. So I just introduce Izzati now before she takes over. So Izzati is actually a very trusted colleague. She's currently doing a PhD with me. I don't know why she would want to, on a very challenging area called cerebral autoregulation and falls. So one day we will get her to blow your minds with her PhD studies, but today we will keep it simple. So then Izzati is now a consultant geriatrician at the University of Malaya Medical Center, and really she runs the falls clinic for me because she organizes me a lot. Yeah, so I'm very grateful that Izzati actually decided to join geriatrics, because the falls clinic would not have happened without her, and I mean it, Izzati. Yeah, so she's actually organizes everything for me. So she's a really good organizer. So over to you, Izzati.
Hello everyone, I'm Izzati, and I've been working with Prof Tan, as Prof Tan said, doing the fall clinic for the past 3 years. Can you guys hear me? Yeah. Are you able to
hear you.
see?
Yes.
Oh, okay. For the past 3 years, so no. So, okay, I'm just going to share with you the typical cases that we see at the falls clinic, and discuss with you on how we can actually bring this to a virtual assessment. As what Prof Tan have been saying just now, actually we are trying very hard not to let our older persons to come to the hospital because of the risk that we're having. And with the pandemic and also going on, and the health crisis that going on is actually force us, kind of force us to do this, to find a better way in assessing our future and looking at it. It's not just because of pandemic. In the future, if it's possible, we want to assess our older persons at home as long as possible so that they are not being exposed to the disease and the illness and all the bugs in the hospital. So anyway, so this is a case about 75 years old. In the gentleman come in being referred from the emergency with fall at home. So usually they rarely come to the hospital after a fall, but when they have complications such as wounds or bruise, they will come for help for the medical attention. And these cases are the one that they will then refer to us. As with other medical illness, we want to know further story on what's going on. Where does it happen? When does it happen? And how does it happen? Because this very detailed history is very important for us to decide whether this fall needs urgent attention or that we can wait a little longer. Of course, we do not want to let the patient ignoring the fall is something that totally no, but we need to re-stratify these patients so that they can have attention equally at the one that seriously needed. So anyway, so we want to see whether it's in the toilet, in house or outside the house area, because the fall that happening along the roadside, unaware, not being seen, are the one that we need to pay more attention to. And we need, if it's in the house, at the toilet, it's quite typical and common area. And if we have someone that can contribute to the history, how severe was the fall, were there any associated jerking movement, then it will help us to further evaluate the seriousness of this fall. When does it usually happen? Majority of the time when they come in, they would say the fall happens in the morning, where they're a little bit drowsy, still sleepy. The one that we are a little bit more worried will be the one that happening anytime, not sure, sometimes in the morning, sometimes at night, sometimes while just walking along the roadside. And of course, the one that happening outside, and the duration of the event. After the fall, do they recover spontaneously or do they need some help? And whether the injury that happened was quite severe. Some associated symptoms is very important, whether they can actually, whether they do have any warning signs, any dizziness, headness, lightheadedness, being unwell a few days before or a few weeks before, and feeling unsure that there's something's going to happen, things like that. There's some warning signs that can help us and guide us in terms of making diagnosis. The one that do not have any warning symptoms, sudden or blackout, history of sudden unawareness and found themselves on the ground, being unconscious, are warning signs too. We want to know what are the complications, because I find that complication after a fall give me a lot of value, because if it's sudden and a blackout, usually the injury would be very severe. They usually occurs on the head area, on the face area, where they are unable to protect themselves because of unaware of things that are going to happen. And this usually comes with fracture or coming into the hospital with needing urgent medical attention, are the one that we think are quite serious. Some will have some minimal laceration, bruise over the hand. It is important to know that we also know that it's serious, but then we can risk satisfy this patient on whether to urgent and need admission or not actually. So for this patient, after for the history, he was saying that he falls for about 3 times for the past 4 months, and usually it's occurred in the morning, and it's because he was about to go to the toilet. He felt that at first it was just a slip and a trip. This is common complaints when we talk to our older adults, that they slip and they tripped and they denied that they actually fall down, until it becomes more frequent and they get worried about it. Then they start telling us the story. Feeling giddy and drowsy in the morning are quite common for him, he said. And however, it recovered spontaneously after he fell on the floor. He also gave some other stories, like felt not well since the first fall, occurring a few days after increasing his antihypertensive medication, which is very common also. The older adults tend to being pushed with a lot of medication, and they start to having feeling tak sedap, tak okay, but they still, because of doctor's advice, they decided to just Okay, doctors must know what's best for me, and hypertension is something that's leading to stroke. So I take my medication very seriously. So yeah, feeling tired, lethargic, but they are usually the one that are fit and well. At the first few fall, they are coping. So we actually need to catch them before they not coping. Other information you want to know, yeah, medication history, their dark history, and their social history. He's staying with his wife. He's an independent person. He has been able to do his gardening and still driving, and he has good cognitive function. Denied being forgetfulness and able to do complex tasks. Able to manage his finance and do grocery on his own. So basically, he's a 75 well gentleman with background history of hypertension and on antihypertensive medication, has recent falls past few months after starting antihypertensive medication. Um, After detailed history, usually you'll be able to get a conclusion what is the cause of the fall. You should be able to exclude at least 70 or 80% that it's not seizure, it's not acute stroke, it's not a newly undiagnosed Parkinsonism or intracranial bleeding or head trauma, that all these are major and needing uh, urgent admission to the hospital. You'll be able to get some medication history. You can simply ask simple question, changes of vision, hearing issue, and undeniably at the end of the session you will come up with the probably a lot of multifactorial cause of fall. It might be due to the drugs. It might be also due to rugs or toilet wasn't really not well lighted, lightning in the house or outside the house, or it can be unexplained fall when we're going to talk about this later lah. So, but before you decide whether the patient need admission or not, you need to kind of know whether the patient is safe or not. So ensure that the patient is safe. At least he is able to find help or call for help when it is needed. Any relative member or family member around, like for this patient, he's staying with his wife, and he are able to understand and follow instruction and cooperate with us. So if they are good clinician, able to understand and they can follow instruction, you can give them um, few advice and suggestion, and can slowly monitor them at home. What assessment would you want to do? Unfortunately, we were thinking of doing this as a chat, but I'm not able to see my chat. Okay. Anybody wants to ask what other assessment that you want to do that you feel that might need the patient to come to the hospital? Anybody want to answer? What do you think we need to do? Besides having thorough history taking, detailed history taking. Of course, you would want to know what are the physical assessment. You want to do some physical assessment on them? Yes, you want to do some table testing if needed. Check vision and hearing cognition. Yes. These are the things that you usually would want to do, and you usually want to ask the patient to come into the hospital to be assessed. But unfortunately, because of the situation that we're having at this point of time, if we can assess them virtually, it would be much better. So if they have a phone that can do video call, then it would be very easy for them and for us, and it can be done. As soon as possible, maybe just a few days after the recent fall. Detailed history taking like I talked just now, and you can actually ask them to show their medication, because dealing with older adults, we find that sometimes they forget, or they do think certain drugs are needed to be mentioned because it's not from your hospital, it's from another hospital. So you will able to let them show off all the medication that they have, all the supplement that they have, and you probably would able to see some bruise, some cuts. They can show you where the lesion is, and you can do again some hearing and visual assessment with them. You can do some simple cognitive assessment tests. Just now Larry have shared with us about picture-based memory impairment scale, blind MOCA, which is motor cognitive assessment, and I think our old school ways is block drawing test. Of course, this is not the best cognitive assessment test, but this can give you a rough idea on how is the cognitive function of the patient at that point of time. Simply draw the face of the clock, put in all the numbers and set the time 10 minutes after 11. I think once they draw it, let them show it to you and you'll be able to see whether it is obviously distorted picture, is it okay, and score it from 1 to 3. Remembering pictures and what you see within a minute, or the blind MOCA. So, you don't have, if you are to wait until the follow-up, only you will be able to do this with the patient. It'll take your follow-up, it will actually cause the meeting longer than you want it to be, because you're not just trying to reduce the frequency of coming to the hospital, you also want to reduce the duration that the patient have to be in the hospital. The other thing that you can do and you need to do if you were to do a visual assessment, false visual assessment, you would want them to do some gait. So with the video that you have, you can ask them to use a chair, simple timer that you can get from, you can use your handphone, because most of the time the handphone do have a timer and a stopwatch. At the hallway, 3 meters, and ask them to sitting position, stand up, walk for 3 meters and turn back. They could time themselves. You want to see if it's less or more than 14 seconds. If it's more than 14 seconds, then you want to consider some very severe gait instability or gait instability. But you also will be able to see patient gait, whether it's an abnormal gait, whether they have limping gait or things like that. You'll be able to see whether the patient is having some fear of falling. Looking at the patient when they are during sitting position trying to get up. Are they moving around? Are they shivering? And you can also look at their knee position, whether it's abnormal knee position, knee OA, the obvious OA versus or valvus knee positioning. This is very important because and it's a very good information to get early on before you meet the patient at the hospital. This is not that bombastic, although it looks like lying and standing blood pressure. It's not that difficult. All you need to do is you just ask them to lie down. You assist them 5 minutes, ask them to take their blood pressure while lying down, and stand up, repeat a similar blood pressure assessment. Usually we advise with Omron. Nowadays I would kind of advise all my patients to have blood pressure machine at home because it's super cheap now compared to before, and it's a very good tool to have, especially when you are aged more than 45 and above, or 60. But anyway, so 0 minute, after 5 minutes of lying down, you check their stable blood pressure, ask them to stand up, repeat another one and another one after 3 minutes. Then you can at least have the rough idea how bad is the blood pressure is, how good it is actually, and then you can simply advise them accordingly also. This is the one that you will not be able to do if you don't have a visual hospital or visual assessment. You can have a visual view on the location of the event at that point of time. So imagine if you have an appointment for a fall clinic and it's 3 months down the line, there's a lot of things that you can do within the 3 months. But if you see the patient a day or two after the fall event, you can actually have the beauty of looking at the toilet itself, looking at the rug and carpet, and having house tour and advising them accordingly on what needs to be done to reduce the risk of them falling down again. So we would want to see their room, of course. They look at their shower, which is toilet. Most common place where patients fall down is actually in-house rather than out of the house. So you look at the common area where they usually walk, the hallway and the stairs. You make sure there is move all the rugs and the furniture, any culprit are being cleaned, and some grab bars or hand railings are being installed to reduce the risk of falling down. Lightning are taken for granted in Malaysia, even though electricity are quite cheap. But I think we tend to want to save our environment, and older adults usually sleep with all the lights off, which is quite dangerous because once they wake up, they are already very drowsy, and finding a switch for them to switch on the light is so far away. So all these are quite common and very simple to be done and should be done very early on after a fall. Oh, actually before. And this is one of the checklists that I found from the internet, prevention checklist. It means it been divided into few topics like medication, tripping hazard, assistant device, exercise, bathroom safety, stairs, and other hazard. You can even give this to your older adults or their family members to help them and guide them in terms of reducing fall risk at home. I would before, and that's if you have a conversation during through virtual assessment. The other things you need to consider is what can they do meanwhile waiting for further assessment or further review with the doctors. They actually do some simple things such as monitoring their frequency of falls. So after a fall, they should be advised to monitor if they have recurrent fall and when or the time of this happening, where does it happen, and the symptoms that occur with it. Because usually our older adults tend to forget or tends to deny that they had a fall. So by the time they come to you, instead of they have been falling 4 or 5 times, they'll say, oh, probably 1 or 2 times. And if you talk to them long enough, suddenly they come up, oh, yeah, I did this and I did that and I did this, I did that. So if they have a monitoring on their frequency of fall, then you would know how severe it is and will help you in terms of knowing the exact location and probably the exact time when it's usually happen. Monitor blood pressure, which is I would advise from the start just now, because sometimes by monitoring the blood pressure, you'll be able to see very early on whether they have overtreated hypertension. Especially our older adults that come to the hospital, they tend to be very anxious and worried and by the time they come to the hospital, their blood pressure at up the roof, especially after that long waiting hours. You can see whether they have bradycardia or tachycardia, so you can even monitor their pulse rate. They do not need to be in the hospital to do all this. So you can do it at home at their usual and comfortable environment. So it's not being influenced by staying in the hospital, being sitting down all day. They can have their usual walking around, doing their job, and they can monitor their blood pressure at the same time. Monitor blood sugar. They can do once or twice a week, but that would be a good information on their blood sugar control. And with all that, this will actually reduce the frequency of visits that needed. So if they are, as I said now, if you know they are safe and they can come to the hospital, they do not need to be admitted. There's no severe illness or injury that need to medical attention. Then you can actually do some consultation via virtually, do detailed history taking, medication history, do some cognitive assessment, gait assessment, and you can do their blood pressure, and then you can reassess them. And it's going to be a better all-rounded consultation at early stage of presentation itself. It's not going to be delayed by appointment that's going to be like 2 or 3 months down the line. And when they come, the consultation time will be very much reduced because the assessment going to be very much focused. So the attention going to be very much focused to what is needed to be done. So when you need to then focus on when do you need to bring them to the hospital, as I said, when you think that the attention for proper physical assessment is warranted, you are unable to conclude any provisional medical diagnosis after the first presentation and after detailed history taking, it's you worry about unexplained cause of falls, that when you need to do further tests such as autonomic function test, you need to do a tilt table test, you're probably feeling worry of sick sinus syndrome that you need an ECG, EEG or CT scan to be done, then you will actually bring them in for admission. Recurrent fall even after consultation, and if they have complication after the fall that leading to severe physical or cognitive function decline after the initial fall, then I think they are warranted to be brought into the hospital. If not, probably, as I said just now, you can take your time and manage them and slowly, by the virtual, there is possibility for you to talk to them a few days after the fall, and then follow up with about 2 weeks or 1 week after a fall, and after a few sessions you might not need to be seeing them that often anymore, and it actually cut down a lot of load to the hospital itself. Okay, I think if there are any questions, what do you think about doing this at your site? Whether it's going to be possible or not?
So suddenly we've gone from really high tech to something that people can just do at home. So how do people feel about something like this? Okay, do you have a standard pro forma to share for falls assessment or virtual fall clinic? Yeah,
Not
we
yet.
have a standard pro forma, and we're very willing to share, right?
Yes.
Yeah. Okay, well, we'll share actually. I've got an algorithm to share with you at the end, but if you need any of the assessment tools you like, they're actually available open access, but if you can't find it, we'll be happy to send it to you. Yeah, Izzati drew a lot of algorithms. So what do you call that? Prof. Chi, the cardiologist, calls ours systems wide algorithm. We don't do anything without algorithms, which drives a lot of geriatricians mad, because it's like, can you imagine, geriatrician is supposed to be an art, and then we've drawn everything into an algorithm. Yeah. So, okay. Yeah. I think the main concern we have is the threat to the physician, isn't it? We still need doctors, and we can just do things like this.
Yeah, I think we still need doctors, but we can actually do it more systematically, rather than everybody needs to come to the hospital, everybody needs to be seen for a long time, everybody needs to be done there and then. But the truth is, usually what we need a very detailed history taking, and then you were able to justify a few investigation, and then off they go. So if you're able to cut down the time and let them just do virtual assessment, and our older adult, by the time they come to the hospital, they are half drained, and I see their face, they're waiting for us, they are so tired, and sometimes by the time they say, I want to go back, I want to go back, they don't want to see me. So I think that there's a lot of difficulty with that itself. You cannot really talk to them, and you cannot really, because they are running out of time, and they themselves rushing to go home by the time they meet you. So
Yun, you wanted to say something? Do you want to unmute yourself and pass and say something? Are you okay?
Hi, Prof and Dr. Izzati. Hi.
yes.
I just find it very good sharing of Izzati, because I think that algorithm is very important, especially in parts, away from Klang Valley. We don't have much geriatric support over here. And even though I haven't started training yet, people are already starting to refer me. So I do find it very difficult. So algorithm will be actually easy, I think, and it's a lot easier to train other people to work with it as well. So we, do things a more systematic way, and we are less likely to miss things.
Yeah.
It's really hard, right? Isn't it, Izzati, to get people to follow algorithms? Doctors don't like to be told what to do. Yeah.
Well, they always say it's because our older adults are very special population. They are very individual kind of person. They have their own, in the end, they are not like one size fits all. But at least if we have an algorithm, we know where to go next, where to do next, and we hopefully find what's the cost, and it'll be easier for everybody to do the same assessment. And when they come into difficulty, they will know where to look for help. I think that's why we need algorithm for we're trying to say that all older adult is the same, but at least we have some steps on how to approach them easily by others juga.
Yeah. Okay. So maybe I could do my case, and then we can all have a group discussion afterwards. Should we do that, Izzati?
Yeah. Yes, that would be
okay. So I'm gonna share now.
I'll stop presenting, right?
Yeah. Okay. Right. So this is the last case, and then we're back to talking boring meetings things. Okay. Right. So this is a simpler case than Izzati's case. So but we swapped it around because I had the algorithm. So we wanted to keep it from you till the end. Yeah, okay. So So this is a regular faller. If there's a common garden faller, actually they're all the same, you know. That's why Izzati said they're all individualized, but actually fallers are all there are a lot of similar features in a lot of our fallers. And so the presentation is always just a fall, and you don't know, it can be anything. Yeah. So so for this case, I'd like you to identify the potential underlying issues. What would you assess in this case normally, and then to replace it with what you can do virtually, and then how would you manage this case normally, and then what can be done and what could be done virtually. I'm not saying everything can be done virtually. I am driving my team totally crazy and potty by trying to do everything virtually. I'm sure my students, my current fellows will tell you all about my virtual walk rounds. But because we're not allowed more than 5 people per walk round, but I have more than 5 people with me in my team. So am I supposed to do a walk round? I mean, I ask 2 of them to sit in the corner, and then I do a walk round with the rest of them. So I just leave the ward and do a virtual walk round, then all of them can join. So anyway, this is back to actually virtual falls. Okay, so Mrs. K, she's a 78-year-old retired teacher, and she was referred from the emergency department, like most of my patients. Okay, unfortunately they wait 9 months before they see me lah. So by that time I cannot do anything already, but it's so hard to change the system. I want to see my patients within 2 weeks of their falls, but people find that really impossible. Yeah, it's like you have a heart attack, you wait until 9 months later to thrombolize them. It's the same thing. My falls is urgent one, cannot wait 9 months. Okay, so anyway, so referred from the emergency department, fall with a cut over the left eyebrow requiring stitches. This is all the emergency department tells me. Okay, I'm already very, very grateful. Okay, that the emergency department actually, whoops, I let the cat out of the bag. Okay, so the emergency department actually referred the patient, and that they identified the falls, because otherwise it will just be laceration, not even a fall. So I'm really very, very grateful already. We have to be grateful for small mercies in geriatrics. Okay, so so what sort of information might you need to know now about this falls? I've given you some sneak information. Okay, please do type in your proposed answer. When, how, when. Yep, okay, so you're listening, you're paying to when, how, and where, right, Union? Yeah, okay. So we want to know when, how, and where. That's what Izzati says. And usually I have to batter it out of the patients in Malaysia, because Malaysian doctors seem to give patients the impression that we can look at them, or just touch their hand and know what's wrong with them. They watch too much of those kung fu movies, you know. So I have to actually batter it out of the patient. Sometimes it gets to be an argument before they will actually give me all the information they need. So after breakfast, got up and started clearing up, and then felt unsteady. Cannot remember what happened next. Only remember that doctor was, next thing she remembered, the doctor was helping her up. She had blood all over her hands. Doctor took her to ED and had a brain scan, showed lacuna infarcts. So told her that maybe it could have been a stroke, don't know. Okay, so what other information do you want to know? Hopefully I was fast enough not for you to see. Okay. So you want to know medical history, medications history. Okay. Who was with Mrs. K? Fantastic. I love that. Okay, so initially, if they come to hospital, all you have is a patient in front of you. So, but if you interview the patient in their own home, I mean, to be honest, I feel that I'm a mother. Yeah, so I would prefer to, I'm very happy to sacrifice some of my evening when all the children are all happily settled, than to actually rush around during the daytime trying to complete my clinic. So I'm okay to actually interview this patient at night when all the family is home. Then I can ask the whole family all together what happened during the falls. Whereas now, if I only have the patient in front of me, then I still have to call the doctor to find out what's happening. So actually doing virtual consultation maybe it might even help with that. Yeah, okay. So past medical histories get very small because all our patients like that one. Yeah. So diabetes, hypertension, osteoporosis, glaucoma. This is actually a short list when it comes to my falls patients, because most of my falls patients are over the age of 80 and they've accumulated many, many diseases. So the mean number of comorbidities in someone over the age of 80 is 5. So this patient is actually below average. So then Medical history, of course, she needs some medications for her diabetes. She needs some medications for hypertension. She needs some medication for her glaucoma. And she needs some medications for her osteoporosis. So these are all of them. Okay. So what do you want to do now? Anyone has any offers? What would you like to do now? Okay, so just a bit more information. She lives with her son and her daughter-in-law, like a lot of Malaysian people do. Okay, I don't know why people would prefer to live with their son and daughter-in-law. Yeah, so as usual, all the grandchildren are studying overseas. And then because her son had stopped her driving last year, so she doesn't go out very much anymore. She needs someone to take her out all the time because nobody taught her how to use call Grab car, and then taxis don't run anymore because of Grab car. No more taxis. And then no, last time our older people used to, the children stopped them driving. They have this friendly taxi driver who take them everywhere. But because of Grab car now, unless you can use a smartphone, they are stuck at home. Yeah, so she's able to manage her own hygiene, can wash the dishes, but then the daughter-in-law does all the shopping and the housework because sit still, otherwise you fall down. So then nobody cooks. Yeah, so everything is bought outside because the daughter-in-law doesn't want her to dirty the kitchen. Okay, what do you want to do now? Vision, hearing, assessment. Yeah, okay. So that's good. Yeah, someone's interested in. So what would you be concerned about? So how do you think how do you think the hearing is going to, that's a really good thing, important thing. We never ask about hearing, but how do you think hearing affects someone's risk of falls? Balance, yeah. Okay, Dini says balance. Yeah, no balance affects the balance. Yeah. So if you have hearing problem, hearing actually contributes a lot to balance. Yeah. So and then we have found that when we in not the combined Malaya and Tua data set, but when we looked at the Malaya data set itself, hearing actually was quite a prominent risk factor for falls. We're trying to get that published. I'm still waiting for Deepa. Deepa's a bit busy now. Yeah. Okay. What else are you concerned about based on her history? So she got up from the chair and then just fell down, cannot remember what happened. So so pre-morbid, as in she's got diabetes, hypertension, yep. So what are you worried about? What potential causes? Okay. So I think Ashikin's trying to say that maybe the diabetes, she could be getting hypoglycemia from the blood sugars. Is that right? Yeah. Anything else? Postural hypotension. Yep. She's on a lot of medications that can cause it. And remember, she fell when she got up from the chair. Okay. Anything else? Lighting, yes. Lighting might be a problem because she might not see where she's going. Maybe the floor is tiled floor, shiny, polished to a shine. Yeah, because daughter-in-law does all the housework and so particular, doesn't like her cooking, so only buy outside. So the floor must be very shiny. Yeah, so then she cannot see. Yeah, okay, because maybe she's got vision problems and she needs her cataracts done. Okay, anything else? What do urinary incontinence? Yep, okay. So joint sense, neuropathy, okay. So those are all relevant actually. You would think, but she wasn't going to the toilet. What do you mean urinary incontinence? But actually what we get, urinary incontinence is huge. So what we have is these old people who don't drink water. So they develop postural hypotension. And then the first thing I say to her is, can you drink more water, 2 liters a day? Oh, you cannot. I'll be going to the toilet all the time. Then they've got urinary incontinence. So the treatment for the postural hypotension is actually, management of it's actually pelvic floor exercises. You'd never imagine that. Yeah, but that's the way it is. Yeah. So joint sense whether she's got neuropathy, so peripheral neuropathy from the diabetes, yeah. Joint position sense in terms of whether she's got osteoarthritis or not, those sort of things, yeah, great. So actually anything, right? Okay. So what would you do to assess this case normally? I'm going to stop sharing for a while so I can type because I think that will work better, right? Okay. Okay. What test might you want to do for this lady? Okay. Any tests you might want to do? Yes, ECG, bloods, lying and standing blood pressure. What other tests might you do for this patient? Muscle power. How would you want to test that, Ashikin? Time up and go. Fantastic. Okay, so we want to do a time up and go. Postural blood pressure. ECG. Okay, anything else? Blood tests. What sort of blood tests do you need, Union? I don't do many bloods because by the time the patients come to me, they've spent hundreds of ringgits on blood already because okay, clock drawing. So you want to test his cognition somewhere, one way or another. Okay. Okay. Anything else? I think that's good to start with, isn't it? Anyone wants to look at the home? Who wants to do a home hazards assessment? Yes, HbA1c. And also, so to look at diabetes control, isn't it? Yeah. Okay. Anemia. Normally, most people would have had FBC done, but yes, anemia is a good one. Okay. We often ignore that. Yeah. Okay. What else? Okay. So we want we also might want to do a home hazards assessment, isn't it? Because it might be the chair. Yeah, the chair is unsteady, so she gets up, then she becomes unsteady. Okay. Okay. So considering these tests, okay, can we maybe I'll just write next to it. So tuck, could we do that virtually? How might we want to do a tuck virtually? A time up and go without seeing the patient. Can we do a time up and go without seeing the patient? Because so far we've done quite well. We can show them a video first. Yes, that's right. Okay, and then get them to do it. Yeah, so you can actually observe, video observation. Okay, or you can actually do the what do you call that? The telephone mobility assessment questionnaire, the TMAQ. Okay, so those are actually potential ways of. So when you do a video, you can do a tug. So somebody's got to measure 3 meters and then time the walk. Or if you're just doing direct observation, you could actually not do a tug, but you can actually do a get up and go test. Yeah. So because get up and go. Get up and go. Yeah. So it's a gug, not a tug. Yeah. So basically, before the tug was invented, we actually did get up and go. So we actually got the patient to sit in a chair, get up, walk a few steps, turn around, and sit back down again. And then someone thought, oh, okay, can we? But you need a doctor to do that. So if we are doctors with direct observation, we don't need a tug. But if we actually get so someone asked, can I just get the healthcare assistant or just a trained non-medic to actually do this? Then they said, yes, all they need is a stopwatch. Then they can actually take away the need for observational skills that needs to be taught. Okay, So, get up and go, time up and go. How about postural BP? Can we do that at home? Yes, again, we can show them a video first, right? Yeah. So there are lots of videos on YouTube that you can do how to do a postural BP. Okay. So what I normally say to them is that all I need is a blood pressure after 3 minutes of standing. I don't even need one lying down. Yeah, and that was actually shown with actual study from Annam, that is actually the standing blood pressure with within 2 or 3 minutes after getting up that actually really matters. So if that one is low, you know that's a problem. Yeah, so you don't necessarily need lying and standing, of course, but lying and standing is better. Yeah, okay. So and then you do a postural or just standing BP. Okay. ECG, can we do that virtually? We can't do a ECG virtually at the moment. Or yes, we can. You can buy an adapter for your smartphone for 250 ringgit. Yeah, okay. But what you can do is actually get them to feel their pulse. Okay, you can teach them how to feel the pulse and tell you whether it's regular or irregular. Yeah, so they can actually tap their pulse out for you. Because all you need to do is get them to do their blood pressure. You get a rate already. Yeah. And then you can also ask them to feel their pulse and whether it's regular or irregular. Yeah, so there's a guy called Mark Sudlow who actually did this study where he went to community centers and got older people to feel their pulses, and he could actually get them to self-diagnose atrial fibrillation. Yeah, I don't know how many talks she gave to get enough to actually do this study. Yeah, but he's a really big professor now. But they can feel the pulse, okay, and they can also get their pulse rate. But the thing is, they might not need to come to hospital for an ECG. Where else might they be able to get an ECG? Go to a GP, a nearby GP clinic, and just ask for an ECG and then take picture and send to you, okay? Yeah, or just a lab, isn't it? Or local laboratory. So they don't have to come to hospital, because what we want is to stop them being stressed and having to come to hospital. Yeah. They can just go in and out then, okay? When it's not busy. Yeah. Okay. Blood tests. If we're going to do a blood test, we need to tell them which tests to do. And they can come into hospital for a blood test, but again, where else can they go for the blood test? Yeah, private labs. We can go to a private lab, okay? So BP, any local private, and in fact, they are not so expensive if you tell them which test to do. So what they need to do is to buy a package. Yeah, people who are private practitioners will be able to tell you more, right? So you go for the diabetes panel, is that right? And that'll cost about 50 ringgit or something like that. So I'm doing private hospitals out of business. But if they want to buy the 400 ringgit package, I'm not going to stop them. But if finances is a problem, then they can actually go for just the diabetes panel. Okay, so there's a BP, any private laboratories. There's loads out there. Okay. Okay, cognitive assessments. We could actually get them to watch them draw a clock. Okay, we can use the PMIS or the blind mocha. Okay. Okay, lots of things. It depends on whether you're using video. This will be doing the video, and these will be actually doing the telephone. Okay, so that one was blood tests. Home hazards assessment. Yeah, for once, having a video consultation is actually advantageous when it comes to home as hazards assessment, isn't it? But but you can actually enhance this by actually you get them to do a home fast non-OT checklist first. So you can send them a checklist beforehand, okay? And then And if you Google Home Fast, there's actually a website now, and Lynette started one, and they can actually do a non OT checklist, and then when you actually video in, you can actually ask them to show you parts of the room and ask them to angle the camera in certain ways. But if they're not very happy to do that, then you can also get them to take pictures to complement that checklist. Yeah. So okay, I can get CGM. What's that? Suspect hypoglycemic unawareness can get CGM. What's CGM, you mean? All these abbreviations. Continuous glucose monitoring. Ayo, can you get hold of it? I've never got hold of it. I thought they were only reserved for young diabetics. That's what our diabetes teams, our ageist diabetologists do. Can get, huh? HTA has a few sets and they give them to old people. That's nice. Okay. So yeah, we can do continuous glucose monitoring. Yeah. Because the problem is the HbA1c might be within normal range, but they actually have very big fluctuations in their blood sugars. Yeah, we tend to get them to do kind of their own blood sugar profile if they actually test their own blood sugars. But I guess the continuous blood glucose monitoring would be very, very, very useful. Okay. So I've given you a few ideas and you've given me a few ideas. That's nice. Okay. So so interventions wise, what interventions are currently on offer? So someone's mentioned virtual lifestyle intervention. Is that right? Okay. Do you offer that at the moment? Is it actually virtual lifestyle intervention? Do you want to unmute yourself and explain what you do with virtual lifestyle intervention? Okay, don't worry. Okay, sure. Okay, we're running out of time. We're having too much fun. Okay, so what interventions are normally on offer? So physiotherapy. How do we send them for this physiotherapy at the moment? Physios, medication management and review. Okay. Okay, says the pharmacist. Okay, anything else? Home hazards prevention. Okay, so hearing aids, cataracts, or other intervention. Okay, lifestyle advice. Those are the things we do, isn't it? So, okay, so what can we do virtually? So this one's interesting because I think that's virtual already. What can you do for physiotherapy virtually? Videos, yeah, videos of videos at the moment, okay, or you can do virtual physios. There are now physios are doing virtual physios, yes. Okay, you can ask them to go to the local pharmacy for pharmacy review. So you don't have to, they don't actually have to be virtual, but could you do virtual medication management and review? Does it actually have to be face to face? Yeah, okay. So they can take pictures of their medications and send to you, or you can actually dial in on video and they can show you pictures of their medications. Yeah, and it's easier because if they forget their medications in hospital, it's really annoying. Whereas if they're at home, they cannot say they forgot their medications. You can go get it. Yeah, snap photos of all the medications. Okay, and then what we're trying out is that we'll tell them which one to reduce, which ones to stop, and then they monitor their own blood pressure, and then we'll connect again a week later, but they can always do this thing called secure texting. Yeah, so we have an app where they can actually text us if they were worried, so they don't have to wait till the next consultation. Okay, so then it actually allows us to fine-tune their medications a lot faster than regular hospital visits, because they can't really come to hospital every week. They'll get very tired. Home hazards intervention is definitely not a problem to do at home. Okay, hearing aids, Yep. They can go to the hearing aid center. Yep. Or as a temporary measure, they can actually order hearing amplifiers. They work on YouTube, on Amazon or Lazada or something like that. Yeah. Okay. And then they can actually go to the hearing aid center. Okay. And that one, they can go to a normal. They can actually go to the what do you call it? Optometry center, but usually if funds are a problem, then that one will have to wait. They can't really do everything virtually. Okay, and lifestyle advice: drink more water, get up. They don't really need to come in. Of course, coming in will give me more quality consultation, but at the moment when they come in, I have to watch the time, watch the clock, cannot spend too long with them. I have to wear face masks, they have to be 1 meter away. Yeah, and then cannot spit at them, so I have to be very careful not to be too vigorous when I talk, otherwise I have to wear a face shield. So those are quite difficult to do in this current moment, and sometimes virtual actually allows you more quality because you can be maskless and you can actually get a better view and you can turn up the volume and things like that. Yeah, so because I actually leave my door open in the falls clinic, because there's no window, no ventilation, so I actually leave the door open. Yeah, so the noise can be quite overwhelming. Okay. So those are things, just an idea of what you guys can do. You can't do everything. So so this is our algorithm. Okay, just present it now. Okay, so it's a bit small, so I've blown it up for you. Okay, quite complicated. Took a while to deliver, and this was actually done by all the specialists in the specific areas. So so it's very advantageous being in a tertiary center when you have everything at your disposal. So we're very willing to share this. Okay, so the tool that we actually use for cognitive assessment normally is one called visual cognitive assessment test. Why? Because no need for language translation. They're all picture. And it's validated in Malaysia and all of Southeast Asia. It was designed by a Singaporean Malaysian who lives in Singapore. So I love it because it's very local, very locally adapted. Apart from the girl in the picture wears a bikini, so they're not very religiously appropriate. So then if they had a cognitive impairment, so they scored below the cutoff of 18, then we would refer to memory clinic. If they didn't, if they had a BCAT of 18 to 22, we assume cognitive impairment, mild cognitive impairment, and they go straight for cognitive training with our OT, who loves it. She loves doing cognitive training. She loves that. Okay, then we measure for postural blood pressure drop. We have a fancy beat-to-beat blood pressure machine that does that very accurately for us, and then costs about 300,000 ringgit. And then if there's called postural drop, if it's slight, then conservative advice. If it's marked, then yeah, and we will actually teach them how to do lifestyle changes, medication review, and then they may need follow-up in falls clinic in the interim, etc. Okay, so then the final thing is we get them to do a time. The other thing is we get them to do. So step 3 is gait and balance. So time up and go. If it's abnormal, if it's more than 13.5 seconds. I can't believe I didn't realize that. And they have got cognitive impairment, we don't send them for physio. We actually address the memory and the blood pressure because we don't want to overburden our patients. We prioritize the memory. Okay, and then whoops. Okay, this is slide 14. Whoops. Hey, what did I do? Okay, so then if their time up and go is not abnormal, then we do a grip strength tests, and then they go. If the grip strength test is a problem, then we actually propose strengthening exercises, and we actually have some exercises on a video as well as in a book soft copy form that we actually pass to them. And then this is Otago exercises for those without cognitive impairment but with physical problems, gait and balance problems. Then we also measured the step 4, the vision. They actually had visual acuity done, and if it was abnormal, they would go to the ophthalmologist. Okay, and then step 5, we actually look for anxiety, depression. If there's anxiety, depression, then they will actually inform, and it's severe, then they will actually need to inform me because I worry. Yeah, so and then I will refer to a psychiatrist. If it's mild, then we actually reassure them that maybe it might get better after we've addressed the risk factors. And if it didn't get better, then we will deal with it. Okay, now this bit is actually social participation, step 6. Yeah, and if their social participation was impaired in terms of reduced quality of life as well, we had a Keel's activity of participation score. If it was more than 1, then we would actually recommend a senior citizens group. So all this is actually done by a research assistant, and with some training. Does not need a medical degree. Okay, so when we went to eLife, we moved to this. So instead of the VCAT, we actually went for PMIS, the picture memory screening tests. And if it was abnormal, then we would actually give them a virtual consultation using an app called TeleMe. If it was not abnormal, then or if it's borderline, then we actually give them a YouTube video to watch to actually do how to do cognitive training. Okay, so then we actually tested for orthostatic hypotension using the OHQ, remember? Of course, it's a bonus if they can actually measure their lying and standing blood pressure if they have a blood pressure machine at home too. And if this showed orthostatic hypotension, slight conservative advice. If it's marked, then we actually give them a virtual consultation through TeleMe. Okay, and then we did the telephone mobility assessment questionnaire. If that was abnormal, then we actually also looked at the cognition. If cognition is abnormal, then we would address that as a priority. If it's not abnormal, they all had Otago exercises sent to them in a YouTube video that they had to follow. And then if it was not abnormal, if the time up and go is not abnormal, we still ask them to do exercise. This is, they're still on the MCO because they're old, so they still must exercise at home. So we send them exercises that they must do at home. Okay, and then visual acuity we decided to omit because we thought that we would actually only be able, we have to assess those face to face. They did have a questionnaire for anxiety, depression, and we are very worried about anxiety, depression at this stage. So if it was abnormal, then I wanted to see them on TeleMe. I don't trust anybody else. But if it was mild, they will be reassured. And we actually suggested that they can also call the befrienders to have a little chat. And then we also asked for issues with social participation. If they had issues with social participation, we would actually give them some ideas of what they can do to stay in touch during the MCO. And these are actually in ready-made websites. Okay, so all this is unfortunately all in English. So if they needed help in PJ, nearly all our participants are actually okay with English. So we do need more Malay, Chinese, and even Tamil versions of a similar intervention. Okay, so so that's the case study, and I'm sure we are now over time as usual. Okay, So